Welcome to tonight's webinar, Introduction to Voluntary Assisted Dying. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. We recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who are joining us tonight. Before we get started, I'd like to just do a quick bit of housekeeping. So throughout the presentations, if you have any questions, please pop them into the Q&A box, which you can access by hovering at the Q&A at the panel on the bottom of your screen. There's also a chat box that's enabled, but please use this for any issues you have, and please keep any questions that you have to the Q&A box. The speakers will try to address questions as we go, and we've allowed time at the end for a Q&A session, which will be facilitated by my colleague, Dr. Brendan Goodger, who is the General Manager for Primary Care Improvement at Central and Eastern Sydney PHN. You can also send your questions anonymously if you would prefer. Yeah, unfortunately, there's no possibility to come off mute. So please use the Q&A box for any questions that you have. Please note the session is being recorded and will be available on our YouTube channel within the next couple of days. And finally, we have an evaluation form at the end of the event that will pop up on your screen, and there'll also be an evaluation form in the follow-up email. We greatly appreciate your feedback and want to ensure that these events are of a high quality and can meet your needs. So any feedback you provide is greatly valued. So we have some upcoming CPD events over the next couple of months. So you can have a look through these in the slide deck that will be sent out in the coming days. I also just wanted to note a new initiative that we've started to increase consumer voices in our programs. So it's called Voices for Health, and you can use the QR code to get some more information, and if you would like to register. And finally, I just want to quickly provide a bit of information for a few new aged care programs we're working on. The first is Healthy Aging Hub, which is a community-based hub that links older people in the community to aged care services. And the second is Care Finders program, which links vulnerable older people with services within the community. And I'll hand over to Dr. Brendan Goodger. Thanks, Brendan.
Thanks, Gloria, and good evening, everyone. The purpose of tonight's webinar is really to provide an overview of voluntary assisted dying in New South Wales, the new legislation, and also about how the implementation update will occur. And to also have a look at how voluntary assisted dying has worked in practice within Victoria. And then Dr. Hespe will give us a summary of the role of general practice in voluntary assisted dying. And next slide. So I would like to introduce tonight's guest speakers. We have Dr. Wade Stedman, who's the clinical lead on New South Wales Health Voluntary Assisted Dying Implementation Team. His presentation will focus on how VAD is being introduced in New South Wales. Then we have Dr. Cam McLaren, a medical oncologist. His presentation will focus on experiences from Victoria. And then, of course, we have the well-known Dr. Charlotte Hespe. Welcome, Charlotte, who's a local GP and member of the New South Wales Health Voluntary Assisted Dying Implementation Team. And her presentation will focus on the role of GPs in supporting implementation of VAD. So, Dr. Stedman, can I hand it over to you now?
Thank you. Thanks for having me, and appreciate you joining us. All so late in the day. I appreciate you probably all had a pretty long day, so thanks for joining us. I'm particularly interested to hear from the other speakers as well. So the idea is I'll really just aim to give you a very general overview of what's been happening in New South Wales and just some of the basics of what that looks like for us. And really keen to get onto the other presentations and really to allow time for questions, because the questions that individual clinicians have vary greatly on their expertise or particular interests. So really keen to get onto that. I'm an intensive care physician. That's sort of my clinical background. I'm now dropped to part-time as a staff specialist from full-time, and then working with the Ministry of Health in this space. There's always already been acknowledgement of country. Thank you. So I'm going to just talk through a quick introduction. I'll gloss over the Commonwealth Criminal Code because we can address that as we go on to questions in the evening. I'll talk about eligibility, participation, talk about the framework in New South Wales, and questions we left for the end of all the presentations.
You want to share your slides?
Sorry, I thought I was just going through those. Let's try again.
I can see those.
Yeah, I'm seeing them.
Oh, perfect.
Great. Can everyone else? Oh, yeah.
Yes, we can see them.
If you can't,
Yeah, we do. We can see them.
let us know. All right. So background, yeah. So the Voluntary Assisted Dying Act was passed in 19th of May last year, and that allowed an 18-month implementation period, which means on the 28th of November this year, eligible people in New South Wales will be able to access voluntary assisted dying. We're the last state in Australia to implement voluntary assisted dying, and that's been a huge advantage for us as an implementation team. And the other states have been very generous with their knowledge sharing, and I'm certainly glad that we're going sixth and not first. So essentially, the focus of this is to obviously go through our legislation, because every state's legislation does actually vary a bit. At a glance, it looks subtle, but when you really dig down, there are significant differences. Essentially, the framework that we're sort of aiming for in New South Wales is that it's a choice that's available to an eligible person who is approaching the end of their life. But importantly, this is in addition to all the choices that people make about their end-of-life care, including palliative care. And they need to really, work together. A fundamental part of the legislative framework is that voluntary assisted dying should complement the person's right to access high-quality palliative care and other services at the end of their life. And then a person's decision to seek information about or access to voluntary assisted dying has no impact on a person's access to high-quality palliative care and good patient-centred care. Who's eligible, to access voluntary assisted dying in New South Wales? You need to be an Australian citizen or permanent resident for at least 3 continuous years, and you need to have been living in New South Wales for at least 12 months. New South Wales does have exemptions for people who have close links to New South Wales. So, and this can be approved by the board. So there may be examples, for instance, where a family live in New South Wales, for example, but their mother or father has been living, interstate for many, many years. As they've become unwell, the mother or fathers decide to move back to New South Wales to be close to family and friends. That they may have had a diagnosis before they've even moved back to New South Wales, or they may become eligible for voluntary assisted dying while they're visiting. So they've got close ties to New South Wales, they've got family in New South Wales, and certainly there is the ability for that to be given leniency for people to access voluntary assisted dying if they've been in New South Wales for under 12 months. You need to have decision-making capacity in relation to voluntary assisted dying and be acting voluntarily and without pressure or duress. You need to have at least one disease, illness, or medical condition that's advanced, and on the balance of probabilities will cause death within 6 months or within 12 months for neurodegenerative diseases. In particular, this is motor neuron disease. It needs to be causing suffering that cannot be relieved in a way that the person considers tolerable. And you need to be able to communicate your requests. And in communicating your request, that can be done through an interpreter, it can be done through gestures, other communication aids. But importantly, you need the decision-making capacity and you need to be able to communicate that decision. So who's then eligible to actually provide the voluntary assisted dying services? Now, I'll refer to authorised practitioners as people who have done the mandatory training in New South Wales. And there's really three types of authorised practitioners. There's the coordinating practitioner, there's the consulting practitioner, and the administering practitioner. Really, the central role to voluntary assisted dying is the coordinating practitioner, and the consulting practitioner gives the second independent opinion, but it's the coordinating practitioner who gives the initial independent assessment of eligibility and then helps coordinate the person's journey through this process. To be a coordinating or consulting practitioner, you need to be a specialist or have held general registration for 10 years. So you need to be quite a senior medical practitioner. To be an administering practitioner, you can be a nurse practitioner, or you can be a medical practitioner who's held general registration for 5 years, or actually be an overseas trained doctor who's an overseas trained specialist who has provisional registration. And importantly, you need to have done this approved mandatory training, which we're developing, which will be about 6 hours of online training. Remember, practitioner involvement is opt-in and health professionals are entitled to conscientiously object to providing voluntary assisted dying. Now, this gives an overview of voluntary assisted dying, and I'll just go through this with you. So, firstly, a patient needs to make a first request. And if the person who they're making the first request to is an authorised practitioner, they can accept the first request and they then become the coordinating practitioner for that person. That coordinating practitioner then does a first assessment where they look at all the eligibility criteria and see if they're eligible for voluntary assisted dying. If the patient's found to be eligible, they then refer for a consulting opinion from a consulting practitioner, and that is a separate independent medical assessment, again, of all the same eligibility criteria for that patient. Now, if at any time the coordinating practitioner or the consulting practitioner need a particular opinion about prognosis, for example, then they can refer to a practitioner for an opinion on that one issue. And the person who's giving that opinion does not need to be an authorised practitioner. So, for example, I could refer to an oncologist about prognosis, and that oncologist could then give me an opinion on prognosis, and they don't need to be an authorised VAD practitioner because I'm not asking them about is the patient eligible for VAD. I'm only asking them about that specific point. Same goes for decision-making capacity. If I wanted a second opinion on that, then I could refer to a psychiatrist, for example, for an opinion about decision-making capacity, but that's all I'm asking. I'm not asking about their overall eligibility. So once a person's been found to meet all the eligibility criteria on those two occasions, they then need to make a written declaration. And the written declaration needs to be done in the presence of two witnesses. It can be done at home. If the person can't sign themselves, they still need two other independent, so they still need two witnesses. So one person to sign on their behalf if they can't sign, and two witnesses. The person then brings that written declaration form back to their coordinating practitioner, and they make a final request for voluntary assisted dying. If they still have decision-making capacity, they're not acting under duress and they still meet the criteria, that practitioner then accepts that final request, does a final review of all the documentation and submits that to the board. Now, the board in New South Wales, which is quite different from other states, is that it has a decision-making capacity, so that it actually needs to approval function, I should say. So the board approves that application, and then they give a substance authority to the consulting practitioner. the coordinating practitioner, the coordinating practitioner then prescribes the substance. And the type of substance they've prescribed depends on the person's administration decision. And in New South Wales, a person can make that decision on whether they want self-administered or whether they want practitioner administered. And the prescription is written relative to what pathway that person wants to take, if indeed both options are available. Because if you can't swallow and you don't have a PEG, for example, well, then you're obviously going to need to go down a practitioner administration route. But a patient who could potentially have both can make that choice. An authorised supplier then supplies the medication to either the patient or to the practitioner, and that's supplied through Royal North Shore Hospital, which is the central statewide pharmacy, and that's delivered, and then that's would probably finish the process there. In the case of self-administration, you need to appoint a contact person. So if you have the substance, it's at home, for example, and you die before you take the substance, then there's the substance still there in your house, and the contact person then has an obligation within the Act to return that substance to an authorised disposer within 14 days, so that there's no substance there unaccountable. So two main parts of the service that are statewide, but both based at Royal North Shore Hospital, is the statewide pharmacy service, which I just mentioned, and the other one is the Care Navigator service. The Care Navigator service is being developed at the moment, and it's a sort of really like a little bit like a call centre, but very detailed, very skilled professionals who are going to be able to take phone calls from patients, families, and practitioners to provide information to the community about voluntary assisted dying. But they'll also have a list of authorised practitioners from across the state. That'll be a private list that's kept for them, but this will be a way that a person could, so for example, if you're a GP and you're asked about voluntary assisted dying, but you're not an authorised practitioner, you could, for example, call the Care Navigator service for more information, and you may even be able to ask for a authorised practitioner in the vicinity of that patient who could contact that person and start the voluntary assisted dying process. So support and tools, as I said, there's a 6 to 8 hour compulsory training for those who want to be an authorised practitioner. And there's going to be a separate overview, a little bit like what I'm doing now, a 10 to 30 minute overview that's going to be on a HETI module, which is like a New South Wales health training platform. But we're going to put it on the platform in such a way that people can access it outside of New South Wales Health. And that's just a general overview for all health practitioners. The digital platform is really an integral way for the practitioners to communicate with the Voluntary Assisted Dying Board, and it also provides an extra level of safety. So, for example, if I'm completing the first assessment, I would need to complete a first assessment form on the digital platform. And on that digital platform, there's various tick boxes that reminds me of all the things that I need to have made sure that I've addressed during my first assessment. So it acts as well as being a method of communicating within the voluntary assisted dying space. It's also a good extra safeguard, but it is not a medical record, but has the same privacy. So I'll stop sharing there, and I'll pass you on to my colleagues. Thank you.
Thank you very much for that, Wade. That was a really great, really detailed presentation, so we're grateful for that. What we might do is continue on the presentation with Dr. McLaren, and what I'm going to do is after Charlotte also speaks, then I've got a few questions lined up, and some are coming through on the chat then, so we'll take those questions then. So welcome, Dr. McLaren. So I look forward to your your presentation.
Good evening. Thank you very much for inviting me. And I must say it's heartening to see 44 participants online. I must say even in Victorian VAD practitioners, we would struggle to get that turnout. So I am aware that some of the people online may be opposed to assisted dying or wanting to learn a little to respect their viewpoint from the get my screen here and talk about my experience. I'm getting a warning that my internet connection is unstable, so please pause me if I start chopping. So I like to start with an introduction about how I fell into this role, and essentially I had no involvement in voluntary assisted dying prior to its legalisation in Victoria. I was a fledgling medical oncologist the year that it came through, only in a year out of completing my training. And when this went live, I looked at it as part of what we do now as oncologists in terms of providing diagnosis till death care. This is something that our patients now had a right to access, and they were going to start asking us for it. So this is that's why I did the training. I was involved in one of the first patients who requested it directly to me, and she was one of my own patients with lung cancer. And through that process, I met the navigators, the pharmacists, all involved. And then sometime after that, they started contacting me, asking me if I would see any patients who weren't my own, because in Victoria, one of the two assessing doctors needs to be a specialist in the area of disease that the patient has. So this led to quite a demand on VAD trained medical oncologists. As about 80% of our applicants had cancer. There still aren't very many medical oncology involvement. Has gone from about subsequently down to 30% and now down to about 10% in total. So I've assessed over 260 patients for their eligibility. I've submitted more eligible and ineligible assessments on the board than any other practitioner. I've been present at many deaths. At my last count, it was 60 deaths of self-administration of the medication, and I've provided intravenous or practitioner administration on over 30 occasions. It's not been enjoyable, but it's been incredibly rewarding work to be involved in, and I'd encourage you all to consider it as best you can. As part of what we did in Victoria, there was a community of practice that was set up for VAD trained doctors, and I expect the same will be set up in New South Wales, and this was a statewide forum for us to discuss how we do what we do, and it was incredibly valuable for us to ask questions such, what would you do, or would you think that this would show enough capacity in this specific context, etc. When WA and Tassie started coming online, we had inquiries asking if they would be able to join our community of practice, and because it was set up purely by our state government, they were not inclined to allow people from other states to join. So I set up VADANS, or VAD Australia New Zealand, which is an organisation that's essentially fills that hole to provide cross-jurisdictional sharing of learning with regards to voluntary assisted dying in Australia and New Zealand. However, the laws are quite different across the ditch, and their support internally has been quite good. So we've had a bit of trouble cracking into them for buy-in, but we certainly look forward to a strong relationship in the future. I hope that my screen is sharing. Now, this is a presentation that I gave a couple of weeks ago to Wales, and it summarises the voluntary assisted dying in Australia over the years. I'm probably going to gloss over this quite a lot, but as you might be aware, Northern Territory was the first jurisdiction in the world actually to have legalised access to assisted death, and that was in 1996 with the Rights of the Terminally Ill Act, and this was overturned in a year's process during that year, and then it was overturned by a Commonwealth law, which has since been repealed, and now Northern Territory and ACT are discussing their own legislation. We came online almost 5 years ago to the day. Western Australia and New Zealand in 2021, Tasmania 2022, Queensland earlier this year, South Australia only recently. I beg your pardon, South Australia coming up soon, and New South Wales, as you're aware, coming up in November. Wade's already been through all the eligibility, but in terms of how that corresponds across the states and jurisdictions, it's fairly similar. So the only big difference I think here is the eligibility in Queensland, where they've opted for a 12 months or less for all comers, for degenerative conditions. Other issues pertaining to VAD in Australia and New Zealand is after the introduction of voluntary assisted dying in Victoria, we realised the interplay between a Commonwealth Criminal Code Act that that may be applied in the voluntary assisted dying space to mean that we cannot transmit material pertaining, or that counsels or incites suicide over a carrier service. So in essence, that can be interpreted to mean that we cannot utilise telehealth services to conduct VAD assessments, which can be problematic for our rural and regional patients, especially those who are within the last 6 months of their lives. Travel may be difficult, painful, or logistically impossible. Since then, the other states noticed that, and they put in their legislation that voluntary assisted dying is specifically not suicide. However, that's yet to be tested between the state and the federal or the overriding federal law, as there's no definition of suicide in federal law. So VAD may be considered assisted suicide federally, so there is still an element of risk, and so telehealth should not be utilised in VAD assessments due to that risk. Every state allows conscientious objection by individuals, and some idiosyncrasies regarding the institutional objection that can be afforded. So more recently in the South Australian, Queensland, New South Wales legislations, allowing for patients to be able to access voluntary assisted dying regardless of whether they live in an objecting institution or are temporary residents in objecting institutions such as a private, such as a hospital. In New South Wales, I believe your mode of administration is also going to be discretionary. Now, when we see that in other jurisdictions, we do see that most patients will opt for intravenous administrations. In Victoria, the default here has been oral, unless they are physically incapable of administration or of ingestion or absorption of that medication. So we're seeing a greater proportion of oral administration down here. I'm going to skip over this because of I don't think it's particularly of interest to you, but looking at other jurisdictions, we can see somewhere between a 0.3 and a 4% of total deaths per year being about the expectation for what we see in terms of assisted dying in any jurisdiction. In Victoria, we started very similarly or very close to the 0.3%. We had 124 in our first year. That has not grown to the 4% that we've seen in Canada. It's gone up steadily, where I think we're around or still below 1%.
Breaking up.
In New South Wales, in terms of raw numbers, you can see the comparative. They can see that just a greater population and deaths per year, so the numbers may be a little higher. You can see, and this is our most recent voluntary assisted dying review board snapshot. So it shows how many first assessments, consulting assessments have been completed. over the, to date. So we've seen to date, that's as of July last year,
You've just dropped out, Cam.
I'm sorry to interrupt you.
1,425 second assessments have been conducted.
Yeah, I'm
Yeah.
sorry to interrupt you. You might want to turn off your
Thank you.
video.
I'm
Just
just
we're
going to-
finding, yeah, just a
Yeah,
little bit
thank you.
sluggish.
I'll do that. I'm not
Thanks.
that pretty anyway.
We'll see how we go. Thank you.
Can I, Wade, I can see you. Can you just nod if you can hear me coming through there?
Yeah,
Okay,
nice and
so
clear.
thank you. So you can see the numbers here now. I'll skip down to, so of the 1,425 patients who initially lodged a first assessment, medication was dispensed to 762 of them for self-administration and 154. So you see quite a great attrition there. So 800 or 900 patients receiving the medication out of 1,400 applicants. Most of those withdrawals have been through death during the process. These patients do tend to present quite late. I think we're not very good at prognosticating, and patients are no better. And my saying has become that patients don't know that they've got 6 months to live until they have 6 weeks left to live. And for a process, especially down here, that takes a significant period of time to access. So as what I guess I'd call a super user, I usually quote patients that it can take about 3 weeks for me to navigate the system for them and organize the medication to them. Although the quickest that I've been able to do this has been 4 days, but that was incredibly difficult and in a very, very patient who was dying terribly. So, so the average is a bit higher than that with less high volume practitioners. I'm just going to flick through. So as you can see, year 3, less than 1% of deaths per year still. The reasons for applying, so we lodge these when we lodge a patient on our portal, and you can see that most patients have multifactorial reasons for applying, most commonly around 4 of these predetermined reasons, and there is an other category there as well, which I'll talk about in a minute. So our community of practice pulled our results of our patients to look at what their reasons for applying for voluntary assisted dying were. I'm sorry if that doesn't project, it's not projecting, but shows too well, that you can see the most common reasons for patients applying for assisted dying being losing autonomy, less able to engage in activities making life enjoyable, and loss of dignity. Pleasingly, inadequate pain control or concern about it is less, and I must say that anecdotally that the majority of those patients who tick that box are more concerned about their future symptoms than have current uncontrolled symptoms, which is also reassuring and also important to keep in mind when managing patients more broadly. The other category, we feel these categories that have been given to us that are modeled on the Oregon system neglect other things, including symptoms other than pain. So we see a lot of patients reporting fear over dyspnea. A lot of people have themes of control over their end of life or previous experiences with death of loved ones, and many feeling an existential distress is contributing to their reason for applying. Most of our patients have a malignant diagnosis. You can see that lung, other GI, colorectal, pancreatic, breast are quite represented. When we break ours down into the categories that we as oncologists use rather than what's reported through the board, we still see GI being quite heavily represented, with thoracic malignancies, genitourinary malignancies, and breast malignancies making up the top 4 organ of origin. I'll skip over this because it's irrelevant to you in New South Wales, but in Victoria, this is about the timeliness and rates of attrition through each of the step. And so you can see the rates of attrition down to the administrations there. like to also talk about it, not just the data and the overall experience, but also the individual experience. And so I do like to talk about a few of my cases. So my very first one was Denise, who was, as I mentioned, one of the first few in the state. She had rapidly progressing lung cancer. I tried some pembrolizumab for her, for those who might be aware of it, some immunotherapy. Unfortunately didn't respond, and she withdrew from treatment. She would remain chair-bound with self-reported no quality of life, and opted to go through the assisted dying process. She self-administered her medication, and I had been told that the medication would take 20 to 30 minutes, or up to an hour, for her to pass away. And she was asleep but still breathing 4.5 hours later. And I was with her and her family the whole time, and at the same time trying to juggle the staying calm in front of the family and freaking out underneath, and stepping outside to call the pharmacy and say what the hell's going on. But that has become, to our knowledge, an outlier. So we have about 5% of cases who have a prolonged time to death. Now, all of these patients fall asleep within 3 to 5 minutes. That's very reliable, but the time until stopping breathing is highly variable. So most patients are within 20 to 30 minutes or up to an hour, but there are a certain proportion that go longer than that. And I've had 2 cases that have gone to 4 and 4.5 hours. That's something that I've been using in my consent discussions with the patient and their family, so that they are aware that that is a possibility. And I do focus on talking to the family about saying that no one has ever woken up from this dose of this medication, and that is a weird type of reassurance. Phil was the patient that I got through in 4 days. He had Lynch syndrome and had multiple previous bowel cancers, and he was dying of metastatic urothelial cancer to his lungs with severe dyspnea. He was on a HOMO too, and had lots of Ordine and subcutaneous morphine, but was had difficult to control symptoms. What complicated his administration, not only was he not able to ingest orally, but the permit and medication delivery came through on Halloween. So whilst we were getting ready, we had trick-or-treaters in the neighborhood, which was very awkward to navigate. Thankfully, Phil's dark humor shone through and broke that awkwardness, and he asked that after we were done, if we could wheel him out to the front yard so that they could win the best decorations for Halloween that year. But we didn't end up doing that. But the dark humor that comes through in some of this is really both inappropriate and helpful at the same time. Lorraine was a conflicting case for me. She was 73 years old. She was a patient of my own, and so I treated her for metastatic cholangiocarcinoma. She had a wonderful response actually to first-line treatment, and had a great period of control, but then she started to progress. She was still well enough for second-line treatment, and I was trying to encourage her to have that, but she declined. The main reason being that the only reason she was going through her treatment and putting herself through the chemotherapy was that she enjoyed her family, and she said, I just don't do that anymore. I don't enjoy my family. I'm too tired. I'm too sick. So no, I don't want to put myself through that anymore, which was an area of great conflict for me. I'd known Lorraine for a long time. She'd bought me I think I've got it somewhere in another room, but bought me a Christmas lamp one year that I still have. And we'd grown to be quite friendly, and so I didn't want her to make that decision, but it wasn't about me and my wishes, it was about her. So that was difficult. Steve was a difficult case as well. So some of these cases are, most of these cases I've put up for illustrations about how this can be difficult in ways other than what we thought to start with. So we thought it was going to be difficult from a prognostication point of view, or from a capacity point of view, or a coercion point of view. But actually what we see is more of these other elements that have been really quite confronting. So Steve was a 59-year-old gentleman with metastatic lung cancer, and I'd just come off the back of a couple of quite urgent cases, and was really looking forward to seeing Steve as quite a clearly eligible case. He still had sorry for the acronyms, but he had metastatic non-small cell lung cancer. He had first-line chemotherapy and second-line immunotherapy, which was the structure of treatments at the time. He had leptomeningeal disease, so disease around his brain, and had whole brain radiotherapy, but still maintained capacity to make decisions. He had a poor performance score, and everyone agreed he had a terrible prognosis. Unfortunately, so Steve brought up his wish to pursue voluntary assisted dying with his family, and they reacted quite negatively to him suggesting that, to the point where Steve felt he couldn't raise it with them anymore. However, one of his sons said that, afterwards he said, "Look, Dad, if that's something that you want to do, then I'll support you." So he went through the whole process with just his son being aware of his application. The rest of his family, including his wife, were not aware of his application. And despite our constant encouragement, there wasn't justification for breaking confidentiality there. All we could do was encourage him to involve the other members of his family. And unfortunately, that never happened. And Steve ended up getting his medication, and then he was admitted to a private hospital that had a policy of not participating in voluntary assisted dying. Steve's son brought the medication in regardless, and he took the medication while his wife was out, not on site. And then she returned, and the ward staff were faced with the prospect of having to tell her that he'd gone through with assisted dying without her even knowing that he was a subject. So it was very, very difficult and awkward. Rick was a lovely guy. He was an ex-serviceman. He had metastatic kidney cancer. Rick had incredibly large volume bone metastases and was very fragile, and he fell in his bathroom one day and fractured a lot of them, and ended up being transferred to the trauma center at the Alfred Hospital, which was about 2 hours away from his home. He called me when he got there and said, "I need to, I need to go through with this. I've left my medication at home. Can you just come and inject me?" And I said, "I'm sorry, Rick. We don't. That's not how this works. We can't just turn that over. Look, I really want you to control your pain. Just get them to give you as much pain control as you need, and then if you're, once you're out of pain, if you still want to do this, then that's fine. But don't do this just because of something that could be made better." But he was very aware that he wasn't really going to recover from this. So he sent his sister to go and pick up his medication. She brought it back to the hospital, and he took it and fell asleep. And just after he'd fallen asleep, the trauma team came through on their ward rounds and were not aware of him taking this or what they'd done, and had not been trained in voluntary assisted dying, and were of the mindset of preserving life at all costs, of course, as trauma teams should do. And the other problem was, as an Easter long weekend, this ward round was staffed by junior staff. There was no consultant on site, and so it was very traumatic for those junior medical officers, and so that was very awkward as well. The lesson I learned out of that is that a case-by-case approach to voluntary assisted dying, as many hospitals have chosen to do down here, is the wrong way to go about it. And there needs to be a clear pathway of how to manage a VAD patient or a patient with a VAD permit when they're admitted. Nicole was lovely. She was 33 years old. She had metastatic synovial sarcoma. So she originally was approved and received her oral medication by 2 other doctors. I was then contacted because she had lost the ability to swallow and needed intravenous. And now, one of the reasons that jurisdictions such as New South Wales have the administering health practitioner is situations such as this, where the assessing practitioners may not be comfortable in administering, but may be comfortable in assessing and prescribing. So, but we don't have that. So the only person who can administer to the medication in Victoria is the coordinating medical practitioner. And the only way that you can become a coordinating medical practitioner is being one of those first 2 assessing doctors. So unfortunately, we had to return Nicole's medication, and I had to go and we had to restart her application from the beginning, from scratch, and create a whole new case for her. When I went to see her the first time, I said, you know, how are you? And she said, I'm just sleeping so terribly, and I'm just exhausted. So as we were going through the process, the next time I went to see her, I said, how did you sleep last night? She said, oh, actually, I slept really well last night because I was able to prop the doona up off my body so it wasn't crushing me. And to have a 33-year-old girl explain that to me, I know many of you listening may be palliative care trained, and that might not be as foreign to you, but for me, it was very confronting and upsetting. So we went through the whole process as quick as we could to provide intravenous administration. So it's been, very rewarding to be able to contribute to some of the jurisdictional differences in the legislation to allow things like administering health practitioners, which we hope to end up getting in Victoria. This is a letter from Nicole's mother to say thank you for the work that I did. This is a text from Nicole's mother 1 year after Nicole's death. And this is a text from Nicole's mother 2 years after Nicole's death. And I've just been emailing her about discussing her case as part of the Victorian review to try and improve our legislation. But again, this means a lot to people, and is incredibly rewarding, but can be very stressful at the same time. I'm just aware of time. Wade, have I got a little bit longer, or Brendan, have I got a little bit longer, or would you like to cut me off?
No, you've got plenty of time.
Thank you. CM was a difficult case, and this was difficult for the reasons of prognostication that I think many of us do fret over. So this was a lady who had right-sided breast cancer. It was hormone receptor positive. She did have a lot of treatment options available. She declined any and all of them, which made her prognosis very difficult. Because we know how to prognosticate for people who have gone through treatments, because on the clinical studies that we do this, we've got average survival rates and all the rest, so we can kind of infer where people are in that journey if they follow that path. But when they don't, it's quite difficult. One of the reasons that she declined any treatment was the list of her drug intolerances was quite extensive. And so she just wasn't open to any treatment. I spoke to her about that. She was making a fully informed decision with capacity. But she didn't want any treatment at all. She presented to me in May of 2020, and she had this CT scan. I think I've made some circles here. So this year we had seen a progression of the tumor. I'm just going to give it a second again as I'm getting my internet warning. So we'd seen progression of the tumor through the anterior chest wall that was threatening the anterior mediastinum. And we'd also seen some reactive lymph nodes as well. But when we look at the scan, we can see this invasive breast cancer here. And on the sagittal views, you can see the extension of that tumor through threatening to the mediastinum there. Compared to the previous scan, that wasn't there. And so I thought, given the rate of progression there, if it grows another certain amount towards that mediastinum, she's at risk of mediastinitis. And if that happens, she will die. So I thought on balance of probabilities, I think she does have less than 6 months. So I assessed her as eligible. A consulting doctor agreed with me. She went through the process fairly flawlessly and received her medication on the 30th of June 2020. She kept coming to see me, I think because I accepted her wish to not have treatment and wasn't trying to, say, take it or leave it. I said, well, if you're not having treatment, we need to get on top of your symptoms. So I was able to provide a bit of palliative care, even though I'm not a palliative care specialist. I do practice some palliative care. and I would help her with some pain. She felt supported in our discussions. Each time I was able to say, look, hey, there's a new treatment on the PBS. What about we try some fulvestrant, etc. That was never fruitful, but it enabled the ongoing availability for her to consider it. She had previously refused palliative care, and then after I'd done a few things with some pain medication, I said, look, this is getting a bit beyond me, and I'd really like you to, at least meet these people and see what they can do. And so she then agreed to that, and we involved the community palliative care services to see her. And after a bit of time, she said, do you think I've got enough time to have another litter of dogs? She had prize winning, or I forget what the terminology that you use, but she had champion dogs. She had found a new GP that she gelled with better as well, so I was able to see her through some of those, and she continued to see a traditional Chinese medicine practitioner who was quite helpful for her, both physically and psychologically. They would assist with lymphatic drainage of the as well. So she had horrible lymphedema. So I said, I don't know if you, it's been a while. I scan. So you'll note this is about a year afterwards. So I thought she had 6 months. And so a year afterwards, we did another scan. And she had progression of her lesion in the chest wall. However, when we look at where that was progressing, you can see here it's probably extended laterally out to this side, if you remember the other picture. And as far as we're concerned here, we're really not seeing that extension back to the mediastinum on this image here. So it had kind of taken a right turn. This is another shot of SCT, and probably just showing the extent of the lymphedema in that right upper limb on the same side. And she obviously couldn't hold it in position for a normal CT scan. So I said, look, this actually looks pretty good. There's no threat to your life at the moment. I think you probably could have a litter of pups, and so she did. She went on to have a few shows with those, and really enjoyed another year. And then on Friday, the 8th of July, 2 years after her receipt of medication, when I was at a conference in Adelaide, I get a message from her partner saying, look, it's time. She says it's time. She had been deteriorating over the previous couple of months with increasing pain and withdrawal and inability to. I got back at 7 o'clock on the Monday, drove, and I had to go past her house anyway. So I said, if you really want to do this, I can be there when I get back. And so I got to her house at 8 o'clock. She did have a delayed time to death. I got home at 2 o'clock in the morning, and then had to do the paperwork that comes with that, including lodging the certificate. We have to report to the coroner down here, and then I had to get up bright and early for clinic the next day. So my takeaway messages from this case is that, yes, our prognostication is inaccurate, but nothing happened to this lady. Prognostication, specifically in untreated disease, is hard, and some patients will elect to have no treatment, and we really don't know some of the pure natural histories of these cases completely untreated, because it's been so long since we had no treatments for these cases. It's not an offense to get the prognosis wrong. This lady had no negative consequences of having her medication for 2 years. She actually was able to have that comfort of having that medication for 2 years, knowing that if that pain and experience got too much for her, she did have another option. So she had 2 years of essentially palliation of some of her end of life fears, through her access to voluntary assisted dying. So I think it contributed greatly to the last 2 years of her life in terms of quality. Other things that I've learned in terms of, I guess through this process is things about performance score, oral intake, rate of deterioration are major factors in when looking at prognostication. There are other ways to prognosticate. There's scoring systems out there. And I think one of the things particularly illustrated by cases such as Lorraine's, who is that cholangiocarcinoma patient I spoke about, is that patient-centered care is actually quite easy when patients do what you want to do or what you recommend, but it's no less important when they don't. So that's probably enough about my experience. I'd really like to answer any questions that you have, but we might move on to the next speaker.
Yeah, look, can I say, Dr. McLaren, thank you very much for that presentation. Hearing those case studies has, I think, been incredibly helpful. We do have some questions, but what we might do is hold them until we hear from Charlotte. Now, look, Charlotte does need no introduction, but I can't help myself. Charlotte is a friend of our PHN. She's a GP clinician, practice owner of Glebe Family Medical Practice. She also finds time to work as head of general practice and primary care research at the University of Notre Dame, actively involved with RSCGP, and she's also a member of the New South Wales Health VAD implementation team. So, Charlotte, over to you.
Thank you. And can I also thank both our speakers prior to me, Wade and Cam, for, I think, providing a really good insight for everybody as we're looking at this in terms of the perspective of sorry, I've just got to find my presentation. So don't mind me, I'm just going to share and hopefully you can.
Yep, go into presenter mode.
I am trying. There we go. How's that? Is that working?
Yep, it's come up.
Okay.
Thanks, Charlotte.
All right. So I'm actually not going to take much time because I knew that really at the end of the day, the issues for us as a GP is what does this actually mean for my patient, which goes back to that whole thing that Cam was talking about there in terms of patient-centred care. And so for us as GPs, the first thing is, well, what does that mean and when does it start? So it's the 23rd of November this year. And understanding that there is these sort of, for me, those three requirements about understanding that any person can ask for medical help. And then if they meet the criterion, they do actually have the right to be able to have the steps to access VAD, and that VAD will be prescribed by a doctor who is eligible. So then that comes back to, well, what does that then mean for me as a GP? Do I have any right in this? We've talked about the rights of patients. So what about the rights for me? So yes, you do have rights. And so you can be a conscientious objector, and it's very clear about what that process is in terms of being allowed to refuse to participate in furthering the request, or in terms of actually processing the request and the assessment process. You have the right to refuse to supply or administer the VAD, and you also have the right to refuse to be present at the time of the administration. And the reason I put those three layers there is because it may well be that you don't have a problem with actually assisting in going forward, but that you don't actually want to be involved in the next two, or you may want to be involved in one of them going down. So I think it's important to know what you can and can't do. But the really, really crucial part of this is that whether or not you're a conscientious objector, if you receive a request from one of your patients to be, about wanting to actually know whether they have a right to VAD and or provide, help that patient to access the services, you must immediately refuse that request in order for it to be fair for that patient to move through the process rapidly. And as part of that refusal, you actually do need to complete a request form that actually notifies the VAD board. And that, for me, that's probably the trickiest part of the whole thing when I sort of think about the patient here, because yes, we have a right to say no, but we do actually need to make sure that patients know what their rights are and not stand in the way of it. Wade, I think, quite nicely talked about the fact that there is Royal North Shore will be coordinating a centre where patients can actually actively access the doctors who can assess them, and also in terms of administering that substance, as well as obviously the pharmacy. But it is really important that you still you do actually need to lodge that form. And so I really want us all to make sure all of our colleagues know and understand that, because it may well be that you end up as a conscientious objector having a patient who actually comes to you and asks you that question. What's going to be quite good for us in terms of GPs is health pathways. Many of you will know I've been a very, very strong supporter of health pathways right from the very first go, when we first got the contracts up and running, which is a long time ago, when we were just back in being a Medicare local prior to being a PHN. And since that time, we're now well over 1,000 pathways. And what will be really useful is that the voluntary assisted dying will have a pathway. So if nothing else, just keep in your mind to be able to know for yourself and for anybody else, if you don't want to progress with knowing anything more, that is where you can find out the information. And it'll be the way in which you access a form and make sure that the process moves on. However, if you're not a conscientious objector and you're sort of very happy to assist in the process more, then you can assist in initiating the VAD conversation. Oopsie, no, I think that's gone too far. That is the one I wanted. Is that you can actually assist in providing the VAD services. And so what, again, Wade talked about what those sort of roles look like, and those roles all actually involve you as a specialist GP. So you can actually be, sorry, I'm just having trouble with the way in which my screen is, that you can be an authorised practitioner, you can be the consulting practitioner, and or you can be the administering practitioner. So the biggest differences really are for A and B is that you do need to have at least 10 years of experience. But if you are a specialist GP, you do actually qualify in terms of being that specialist medical practitioner. To be eligible as C, you actually only need to have 5 years experience. But you do need to have completed the approved training, and you absolutely need to not be related to the patient nor be benefiting from their death, and any other requirements that the regulators do impose upon us in the meantime. So I think in terms of what that means, we were sort of here, we heard the process and we saw that the whole length of the continuum for the patient. But as I said, I'm coming from it from a GP perspective to say, if you are interested in doing this for your patients, then you do then actually need to complete the approved training. What I'm hearing from GPs is that there's a lot of GPs who are quite happy to be involved in VAD, but don't actually want to get involved first because they don't really know what it's going to look like, and they don't really want to be obliged to do anything, and that's fine. You can not do your approved training until you actually realise that you have a patient who may actually want to ask you, and you want to be able to assist them as that authorised practitioner, in which case you can then complete that approved training, which at the moment is not available. You have to wait. It's all being developed so that it will be ready to rock and roll. I'm told that the time of training should be ready to go by August is the time frame. I know Wade can confirm that for us. And then finally, that next one, whoopsie, is about just some of these conversations about what other choices do we have. Do you have the right to initiate the voluntary assisted dying conversation? Certainly down in Victoria when it started, and Cam can clarify this for us, that was not actually the case. Well, in New South Wales, we can initiate the VAD conversation, but it just needs to be in the right context and seen as not being coercive or in any way trying to persuade the patient one way or the other. You do need to undertake education and training if you want to participate as those authorised or assisting practitioners, but you don't need to if you actually still want to have the conversations with your patients when they ask you. If you are a conscientious objector but want to assist them, then that's when it's so important to know the services that you can actually help, and that is in terms of the Royal North Shore centre is going to be absolutely fabulous for GPs who want to be able to assist but not actually participate. And again, the health pathways will assist you in knowing how to do that, and give you the numbers to sort of ring and how to facilitate the patients going forward. Remembering that if you don't participate, there will be some potentially that form that you might need to fill out as you pass them over to the Northfield Clinic. Then finally, in terms of what support will we get, there will be counselling and support. And again, thank you, Cam, for sharing for you the experience of being involved in it at such an involved level. I think that we would all absolutely relate to that. For us, there are patient stories for where really this may not be the journey you choose, but you want to try and make sure that your patient receives the best possible care under what they choose to be. And so that's what we can facilitate as GPs going forward. So I'm just going to stop that sharing there because I didn't want to go on any more than that, and just instead open up for the questions as soon as possible. And thank you for running this session.
Thanks, Charlotte. We've had 3 fantastic presentations tonight, and I'm really grateful for all for the panelists. And really,
I'm afraid, Brendan, you're not good connection either now. We've gone from phone to
Okay, let's try that now. So
it's contagious. Sorry, Brendan.
It's catching, is it? How can an individual be better supported when family members are faced? Take that one.
I don't think it came out, but it's basically about the members, when family members of faith are resistant to that. So maybe Wade, I know we've talked about this a lot, and Cam will have experienced.
Yeah, great to get Cam's practical experience on this, but essentially health privacy laws, obviously very strong. So important in the example that Cam illustrated that if a patient doesn't want to share their medical information with family, despite all the best intentions from practitioners and the team, it's not our information to share. So we certainly can't force a patient to share that information. I think if there's conflict within family, I think that's inevitable, really, over time, as you all know from working in general practice as well. And I suppose we just need to do our best to try and address that and to help that patient navigate, their particular situation. It's very hard to give general guidance that's going to help us for every circumstance, but it is something that we're going to have to address probably on a patient-by-patient basis.
So this sort of gets at the next question. It's a little bit of a follow-on from that in a way, which is what safeguards are there in place to ensure there's no coercion that may impact the patient's decision? How can we truly be sure of this? So I just want to throw that open actually to all members of the panel, if I may. Perhaps starting with you, Cam. Any suggestions for that?
Yeah, and I think there's a bit of crossover between the previous question. So thanks, Barbara and Jessica. Now, so just on the previous question with Barbara, I think it's really important to respect both sides of the equation there and to not insert yourself too much in this situation. You really need to ensure support of the patient and support the family, and make sure that everyone feels as though their views and position on the topic are valid because they are. Supporting the patient, which is our primary, just be really difficult for you. Do you have someone that you can talk to? I'm just seeing my internet connection warning again. That seems okay now. So I think it's really important to have, to not just treat the patient, but treat them both. You can often see coercion in these situations actually against VAD. So in a similar situation, family members of faith saying, "Don't do this, Dad. You shouldn't do this." You know, there is actually a lot of coercion there. What I've actually grown to realize is that there is a lot of coercion that affects these patients towards the end of their life already. A lot of that is to do with, you know, especially they're having chemo because of their family, because their family wants, you know, oh, I better do it because you know, my family would want me to. So there's already a lot of that going on, but it tends to be more the opposite direction. So you know, I'm having the chemo because my family want me to. I don't know if I want to do VAD, you know, I want VAD, but I don't want to bring it up because I don't want to upset my family. So we're seeing that much more commonly than we're seeing the other way around. The biggest, or I guess the biggest near miss that I've had with a case of coercion is where the husband of the partner called me and said, "Look, we've never spoken about assisted dying. I just don't understand where it's come from. I'm worried that my son has mentioned it to her and that he may have talked her into this." This was really quite early on, and that was, you know, big alarm bells for me as being, oh, this is it. This is what we were all worried about. So I did a home visit every day that week and spoke to her individually. I spoke to them as a group, as a family, one-on-ones with all of them, to the point where, and then it came out, the husband actually contacted me and said, "Look, we've actually had another discussion," and she said it's how she found out that this was a possibility. But once she found out that it was a possibility, it was definitely her wish. So finding out about this is very different to coercion. So that's not coercion. That's information sharing. But going there every day, taking this seriously, being, you know, I think I was being a responsible assessor in doing that, in over assessing this patient. I think I recorded her talking about her wish in case this ever came out, with her permission, of course, and not for distribution. I just said, if I'm ever, you know, questioned about this decision, or if this ever comes out, I need to show them why I felt that coercion wasn't an issue here, and I'd really like to have that. And she said, of course, you know. So that's some of the things that I've kind of done across the time. But a lot of the times we are dealing with coercion against rather than coercion towards.
So thank you for that. But I might throw now to Wade. In terms of the New South Wales legislation, again, how do we try and safeguard against the issue of coercion?
Yeah, I think Cam's given such a great example. It's really about listening to families, listening to patients, and taking a thorough history. Regarding the legislation, within the first assessment and then the subsequent consulting assessment, if either of those practitioners are concerned that there's some coercion, they can refer for an opinion to a medical practitioner or to another person, a medical practitioner, a health practitioner, or other person who has expertise in that area. So that could be, you know, another doctor, social worker, you know, lawyer potentially. You know, so within the Act, you know, there is a way that a person can refer for an opinion for coercion. The experience I've heard from Queensland, I was up there recently speaking to some practitioners, it really fits with what Cam's described there, in that they are doing a bit of telehealth in Queensland. They're doing it particularly for the consulting assessment. They're not doing it for the first assessment from the coordinating practitioner, and they're certainly not doing it with administration decisions, because that's a clear breach of the code. But they're doing it for a consulting assessment. And in their experience, if there is any concern about coercion, that is when telehealth maybe falls down, and that's when they would then opt to go or not just because of that, but that would certainly encourage them to have a more face-to-face contact. Because you know who's in the room, you can read the body language, you can really take in a little bit more about what's exactly going on. So telehealth has the Commonwealth Criminal Code issue with that, but but it does fall down, I think, also as a clinical assessment tool in some circumstances, it might seem.
Can I just add a little bit about the criminal code and the telehealth? So this is, I guess, advanced VAD assessment. So I would recommend, not doing unless you're comfortable. But what the Commonwealth Criminal Code says is it is illegal to transmit material that can you hear me coming through there?
Breaking up slightly. Pam?
Yeah,
Try again.
I just saw the alarm come on. Can you hear me there, Brendan?
Yep, we can hear you now.
So what the Criminal Code Act says is that it is illegal to transmit material that encourages or incites or counsels suicide to an individual with the intent that that material is utilized to commit suicide or for those purposes. In conducting an assessment, it is possible to conduct an assessment without transmitting any material. So I can have a conversation over telehealth with a patient to ask them questions, and they can transmit all of the material to me. So as a consulting assessment, that can be done, because you just say, look, this is going to be a really weird conversation. I'm going to ask you a lot of questions. We're going to have a discussion. At the end of it, I'm not allowed to tell you the outcome of this conversation or talk about this process in any way. And I will feed the result of my assessment back to the coordinating medical practitioner, and you can talk about that with them in person. So you can conduct a consulting assessment via telehealth without jeopardizing the criminal code. It does not make for good medicine. It would be much better to be able to discuss, answer questions, transmit that material, but the law is the law until clarification comes through.
Look, thanks for those answers. I've got a question now for Charlotte, which is really the question around funding. And it's a question I get a lot from GPs in relation to that. I sit on myself 3 different local VAD committees. And the questions I get asked are, so will GPs be paid to do the training? Will they be paid to do the training?
No, not at this point in time. So not unless where anything radically changes. This is a voluntary thing. And can I say that we will also not be being paid for the consultation time involved. And I think that's where, for a lot of GPs, it may well be that they want to be the facilitator, so to speak, in that they're listening to their patient's story and they make sure they access the service, but they don't actually see themselves as having a role in being any of the A, B or C of the VAD. And I think that sits very well with what we do a lot of the time as GPs, is that we very much coordinate care. We are the sort of the care champions, and we make sure that our patient's voice is heard and that they get to the right people in the right places. And that's what I would love to know that all the GPs in New South Wales will do that, whether or not they actually become part of the VAD process, that they facilitate their patients' care needs, which goes to, some of that stuff about coercion. Sometimes we do know that that the person that we are looking after is being coerced exactly described into having more treatment than they would otherwise really want to do. And so you do know that really when they say they want to know more about something like voluntary assisted dying, that is something that we need to do, and then make sure that it's done in a way that is particularly sensitive to the situation that they're in, because you might know the family situation very well for years of care. Did that answer the question?
It does. Thank you for that. Again, it's a really common question. Please,
add quickly to that. Charlotte's just described that so beautifully. The coordinating practitioner is coming into this potentially. Ideally, someone like Cam, on many occasions, the patient, and you provide that continuity. You probably know a little bit about the social situation, the family dynamics, and really that sort of plays into how you then can assess things like duress and coercion and decision-making capacity, because you're already well ahead of the game on knowing a lot of that. But a consulting practitioner or coordinating, practitioner who's coming in to do a first assessment who potentially has never met the patient, it's a very different situation, and they may really want to rely on the GP. They might want to, as good medical care, they might want to get a bit more information. Contact the GP, speak to the GP about the patient, get a bit more history, and GPs are just so well placed to help fill in some of those gaps. So thanks, Charlotte, for speaking about that.
Yeah, look, thanks, Charlotte, and also thanks, Wade, for your follow-up. Now, another question for Cam. Now, Cam, I do a fair amount of work in the area of aged care, and the question that has often been asked in the last few months is, how do you go about assessing people who've lost capacity through dementia or stroke? So it's this issue around capacity.
Yeah, so if they've lost capacity, they can't really participate in this. This isn't something that can be delegated to a medical treatment decision maker or nominated in an advanced care directive. But that is a delicate conversation to have with family, particularly if the conversation of saying he would have never wanted this, he never wanted to end up like this. Can't we do something? What about this new VAD? It's a very delicate discussion to explain. Look, the legislation unfortunately specifies that a patient must have capacity with regards to end-of-life care discussions, and unfortunately that's not the case at the moment, and unfortunately that's not an option. But what we can do is this, that, the other, and we focus on what we can do. Now, the confusion and the difficulties often come when you have someone who has dementia or a stroke, but still may have a grey area about capacity and may not have capacity in all aspects of their care, but understands this and wants this. Now, dementia, stroke would not be a qualifying medical condition under Victorian legislation, and I don't believe under New South Wales legislation either. So that needs to be carefully discussed with the patient and their family as well. But someone who has, say, early to middle stage dementia or has had a stroke, who also happens to have cancer with a prognosis of less than 6 months, now they may be eligible. So then that takes a very careful capacity assessment. And I always talk about 3 things: that they must be able to receive information, they must be able to process it and incorporate it into their decision-making process, and they have to be able to communicate a reasoned response in response to that information. So that then displays their capacity. And it's actually very useful to have definitions like that because then you can display the lack of that to their family. So often I say, look, in order for this to proceed, he needs to be able to do this, that, and that. I'm going to have a discussion with him now and see and explore that. So then you're demonstrating to them that they do or do not have capacity, so that you're involving them. And that way that you're also getting ahead of some of those concerns that may come out from family members later down the track, just saying, oh, I don't know how he did that. He obviously didn't have capacity. So if you actually demonstrate it in real time, then you have, you've shown them that does come with, sorry, internet problem again. But just the communication skills required to delicately discuss the lack of capacity and inability to progress with this is very careful. There's a lot of nuance there, so it takes a lot of gentle communication to do that well.
Look, thanks for that. Yeah, I think that's covered it, but thank you. Look, one of the things that we also know too, that when you are dealing with someone who is potentially confronting end-of-life decisions, there's a whole variety of different healthcare professionals who are involved in that person's care, and they have, influence and the ability to provide that support as well. So my question is really to Wade and to Charlotte, which is for people like, it might be a practice nurse, it might be allied health professionals who may not be directly involved, but they're certainly informing that patient's care, and obviously discussing that potentially. What training will there be available for them?
So regarding formal training, there's there's going to be the overview. So there's going to be that 10 to 30 minute overview, which is probably not dissimilar to what I've sort of given you tonight. Is just like a general, this is the legislation, eligibility. We're working on a third training. So there's the mandatory long training for authorised practitioners. There's this short version, and we're working on an intermediate training for those practitioners who are going to be involved, as you described, palliative care nurse, GP nurse practitioner, or any combination of allied health, who want to know a little bit more information. So that, just be due to time constraints, that third tranche of training may not be ready for November 28, but we're hoping it will be. So the only formal training will be that shorter version. The Voluntary Assisted Dying handbook that Charlotte has helped develop along with the clinical advisory group, although that's designed very much for coordinating, consulting practitioners, because it's very detailed, that will be open access information. So if someone was particularly interested and wanted to dive in a little bit more into detail, then that handbook will be available to look at. Yep.
So what I would add is that we're friends with Allied Health and good friends with the PHN. We would welcome the opportunity, and we'll be making sure we do this, providing education to our Allied Health colleagues in relation to that. So we'll certainly be running some webinars in relation to that as well. Cam, you've got your hand up.
I do. Thank you, Brent. I just thought that was a good opportunity. So we found implementation really does need to be around legislative compliance and making sure this is done properly. And one of the spaces that we felt needed to be filled, and what VADANS hopes to fill as well, is in some of the, not only how to do it properly and well from a process and legalistic point of view, but also how to deal with some of these aspects and how to learn how to do VAD good. So we have some resources available on our website. Our plan is to implement a lot more. We're going to have position statements on aspects of legislation, etc. So as a growing body, we hope to be the peak body representing VAD practitioners and have resources available in order to learn how to do this properly. In that theme, if I can just put in a quick plug, we've got the National VAD Conference in, I think it's September this year. It's very, very close, or even right next door to the New South Wales Implementation Conference as well. So we're going to have discussions about how it's been across all the states, problems, and how we've looked at that as well. So if that's of interest to anyone, I'd be happy to share details.
Look, thank you for that, and we're happy to send out those conference details. We love a good conference, so we'll send that out. Now, again, just a broader question for you, Cam. Really respecting the fact that you've been involved in this for quite a few years now. What do you think have been the major challenges that have happened in Victoria that you think might inform the rollout here in New South Wales?
Uptake within doctors, and has been, I guess, probably my biggest bugbear, particularly with, so doctors are conservative, medical oncologists are conservative doctors, and with our legislation requiring one of the two, we've got very few of us available, let alone few of us, let alone those of us who will actually do a home visit rather than sit in our ivory tower and prescribe chemo. So that's been difficult. As the workforce has been very, very difficult for us. I think that will be hopefully better in New South Wales and other states where we see the lack of a need for a specialist to be one of the non-GP specialist in the area of disease, to be one of the two assessing doctors. I think that's one way around that. But early on, I think it's going to be really difficult in every jurisdiction to have the workforce to meet the need, because you are going to see a lot of patients who are hanging out for this, who are definitely within the last 6 months of their life, and probably much shorter than that. So on the first day of the program, you're going to need practitioners ready, willing, and able to see patients. And so I really would encourage people not to sit on the fence. I think there's a lot of tendency for doctors to say, oh, look, I'm going to do it, but I just don't want to really leave patients wanting. So please do participate early if possible. I think funding is a big issue with regards to that as well, and encouraging doctors to undertake unpaid training. That's not unreasonable. That's something that we do all anyway. I presume it could be counted towards CME as well, but then also, we talk about coordinating a case or a case taking around somewhere between 8 and 12 hours of work to navigate, and that's including coordinating and consulting assessment. So, some people might be willing to do that on the odd occasion, but it's difficult if that becomes a significant part of what you do in order to do that gratis. So I think the funding model needs to be very clear. Need to concentrate some of that experience of patients on a regular basis so that you can develop that experience early.
Yeah, look, thank you for that. And look, I've got a question for Charlotte, if I may. Again, it's a question I got in relation to another initiative, which is, Charlotte, have GPs been heavily involved in VAD in New South Wales? Because I think GPs want some sort of reassurance that they've been strongly represented, that they've had strong involvement in VAD. I wonder if you could make some comments on that.
Well, I think we've had GP voice on all of the committees. I think Wade's overseen the implementation committee, which has actually got specialists across the board. Obviously, with an increased amount of people who are in palliative care, oncology, etc. But general practice has had representation. There's 2 of us on that committee. I don't think you could argue that we could have had more of us, but at the end of the day, I felt very comfortable that the voices have been very much around making sure that the legislation is exactly as Cam has discussed, implemented in a way that is in total alignment with what it is that the requirements are, but at the same time, making sure that it is very patient-centred and also very mindful of how difficult this is for a lot of practitioners who are highly conservative and not sure what this is going to look like. And trying to make sure then those who are, happy to facilitate the implementation in the first place aren't burdened too much either, and that all the resources are there for them. It's going to be what it is. It is about patient-centred care, and GPs at the end of the day are part of VAD. We see every single patient who is going to be wanting to put their hand up, but we may not necessarily be that person that needs to be the first conversation or otherwise, depending upon what illness it is that the patients have. But I'm sure that we will be very much frontline. So yes, we do need to be part of it, and I feel comfortable that the process is as GP-centric as it can be. Wade, do you want to make a comment?
Yeah, we've added some extra, which goes in, follows on nicely for what Cam and Charlotte have just mentioned. New South Wales is over 8 million people. We're diverse, more diverse than every state from a cultural and linguistic background, and our geography is much more decentralised than other states. So we have real challenges, and we see that the workforce is going to be a huge problem for us. So one of the things that we've done is we've got funding for 3 full-time equivalent VMOs that are based through the Ministry of Health at North Sydney Local Health District, and we've appointed 9 people to that 3 FTE, so varying fractions, some 0.2, some 0.4. And 6 of those 9 are general practitioners. So the idea being that this is currently not funded practitioner GPs, but you know, it should be because you know they're fantastic, you know, community practitioners. This is where I see, you know, VAD probably should be. Anyway, so this is a way that we can have people who are paid per hour, you know, to do this really difficult and detailed work, but also we've deliberately tried to employ general practitioners as our preference, so that they bring those expertise to this program, and 3 of those have already started. Sorry,
the generalist perspective, not the bit of you, it's the whole of you.
Exactly, and you know, it's been fantastic. Two of those GPs have already started with me and helping me with implementation, and already, you know, I'm seeing things that I hadn't seen or thought of. So I think GPs are getting hopefully you know, the representation that we need for good patient care.
Yeah, look, thank you for that. And can I put a bit of a shout out here, which is I sit on the VAD implementation committees for both South East Sydney and also Sydney Local Health District. I'm always after GPs. We'll pay them to attend those VAD committees. So if there's a GP out there who wants to join one of those local VAD implementation committees, Gloria, if you can put my email in the chat, you'll be hearing from me tomorrow. All right. So we're really keen to get GPs on those VAD committees, and they've been extraordinarily effective. And I note too that we've now got local VAD coordinators that have been appointed in both local health districts. So they're really now starting to get out that education and really starting to get things happening at a local level. That also ties in with the work that Wade is doing from a statewide perspective. Look, we're coming to the end of our webinar tonight. I think it's been a really fantastic webinar tonight. We've had Wade give us that big statewide perspective in terms of how things are going to be implemented. We've had Cam give us his many years of experience from Victoria. Running through those case examples was, I think, particularly helpful. As we've been chatting tonight, Cam, I've got a couple of text messages coming from GPs who've been attending tonight saying how grateful they were for those case studies. And then, of course, we've got Charlotte, practicing GP at the cold front, who's been involved also in representing GPs. We're really grateful for the work that you do, Charlotte. So again, a really fantastic panel, really good presentations. So we thank you for that. This won't be the last webinar that we're having. We intend to do more. Our PHN has a strong perspective in terms of supporting the implementation of VAD. We will continue to do that. Gloria is our palliative care project officer, and so we'll be running more webinars. So can I thank you all? Can I thank all those people who asked questions on the chat tonight? Thank you very much. I think we've addressed all of them. And we look forward to seeing you soon at the next webinar. So have a good evening, everyone, and my thanks to all.